All right. Well, good morning, and thanks so much for the opportunity to present. You've been working hard on our surgery seat grant, and of course, there's a lot of help that I acknowledge towards the end. But I'd like to just share some of the results and some of the data we found, and I think we're really excited about what's coming. Just as background, and I think I want to set the tone right to understand why we're studying this patient population. So obesity is increasing in children. It's a very fast growing population, unfortunately. And as you see in this graph, it just keeps growing. And the other interesting thing is young children and adolescents with obesity will turn into adults with obesity. All the stories of the grandmas tell you that you're going to stretch out as you grow older and not be obese. It's not true. You continue to be obese. About 80 to 85% of these patients will continue to be severely obese adults. So it is a huge national and worldwide issue. And on top of that, Hispanic and Black children are particularly affected with earlier onset and longer time course, as you can see in this graph, compared to Asian and non-Hispanic white population. So it is quite worrisome, and this population is particularly at risk. Another study showed, just to continue to set the tone here, is that there are clear benefits of metabolic bariatric surgery over medical treatment for both adults and children with severe obesity. That's pretty clear. But if you look at this study in 2018, 1.6 million adolescents had severe obesity in the nation. And only 2,500 of these patients had surgery to treat it. So that's a 0.15% rate of surgical therapy. And if you compare that to any other disease we treat, where we show that surgery clearly gives you the benefits and also clearly outweigh the risks of surgery, is a very, very low surgical therapy rate. And that's also very concerning. And Hispanic adolescents with severe obesity are less likely to undergo metabolic surgeries. Not only children are less likely, but if you're a Hispanic child, you're also less likely, as you can see from this study, where white adolescents who underwent bariatric surgery at a higher proportion than their Black or Hispanic counterparts. And to finish, Hispanic adolescents with severe obesity are also more likely to have insulin resistance and diabetes compared to their counterparts. So it is a very high risk population. So what we wanted to study and prove is that metabolic bariatric surgery has a strong impact on the remission of metabolic syndrome and diabetes in the Hispanic children with severe obesity. And again, since Hispanic children have a higher incidence of obesity, have a higher incidence of insulin resistance and diabetes, and on top of that are less likely to undergo bariatric surgery, I think the whole point of the study is to conclude that we need to advocate for early referrals to specialized centers in this particular patient population. And that's what we wanted to show with our study. So we basically enrolled severely obese Hispanic patients with either diabetes or metabolic syndrome, with a BMI of higher than 35, which is our cutoff for indication for bariatric surgery, basically with elevated hemoglobin A1Cs and insulin levels. We did sleeve gastrectomies on these patients, and this grant was in 2020, so we knew we were going to have a short follow-up. So we sort of put more patients together in a retrospective and prospective fashion when we started doing the study. So the period ends up being 2015 to 2021. But we want to just keep the follow-up and be true to the study that we're doing, which is the max we can do so far is 3 to 6 months. But of course, the study continues to be, continues. So, but I just want to report that sort of short-term follow-up, which is part of our seed grant. And then we compared both groups, meaning the Hispanic to a control group of non-Hispanic patients. So what we saw is that of all the patients we could enroll, which were 136, meaning that they had insulin resistance or prediabetes, only 97 completed at least 3-month follow-up, which includes a clinic and a lab follow-up. So almost 100 patients, and half of them were Hispanic. And both in the Hispanic and non-Hispanic population, we had a similar loss to follow-up rate. And you have to understand that the whole population is underserved. So not only the Hispanic patients, but severe obesity is an underserved population, a population at risk. So you'll see that there's not a lot of difference between Hispanic and non-Hispanic as we move along. The mean age was about 16.5 in both groups, and the mean BMI was about 47 in both groups. There was no difference. Fortunately, we had no reoperations, no strictures or leaks in this patient population, and we had 2 readmissions for dehydration. Now, like I said, the follow-up is short. It's 100 plus minus 20 days. So what we found in those months is that the BMI dropped from 47 to 40, which was a significant drop. And the mean total weight loss in both Hispanic and non-Hispanic was very similar, with about 15% plus or minus 4, which that's a decent number, and actually is a pretty good result at such a short-term follow-up. The other interesting thing we found is that preoperative insulin levels were much higher in the Hispanic population compared to the non-Hispanic population, which is pretty consistent with what the literature shows. And the preoperative hemoglobin A1Cs were also higher in the Hispanic compared to the non-Hispanic population. Now, when we look at the pre-op and follow-up findings for hemoglobin A1Cs and insulin levels, we can see that they dropped in both groups. Even though we had no significant differences, we compare the control group to the Hispanic, we see a good drop on both values. So this study was, has several limitations. Number one, when we compare ourselves to the adult numbers, they're very, very small. But still, it's a pretty decent number. We have an accredited center in our hospital, which is the only accredited center in the West Coast and only 1 of 5 in the nation. So it's still a very rare practice. It's still a destination center for us, and we operate about 30 to 40 patients a year, starting about 3 to 4 years ago. So when we compare ourselves to the mean and what other institutions operate, we're on the higher percentile. So we have good numbers, but it'll never be the numbers that we see in the adults, which is pretty consistent with everything we do in pediatric surgery, unfortunately. It is a short-term follow-up. The study continues, though. The pandemic affected us significantly, though. It was sort of right in the middle when we were trying to study these patients. We changed all of our clinic follow-ups to telehealth. And as you can imagine, it was hard to get the labs and check BMIs on the screen. So we really needed these patients. We had to rely on them to show up to a lab and get those tests done. And of course, the changes in the hemoglobin A1C will take a little bit longer. So we continue to study these patients. So basically, we see that Hispanic children have a higher risk of insulin resistance and metabolic syndrome. And we prove that. We see that they have a really good result just a few months after surgery on their markers for prediabetes, metabolic syndrome, and diabetes. So there is a very strong impact of this type of operation in the Hispanic population. They are more prone to metabolic syndrome and obesity-related diabetes, so we have to focus on this patient population and advocate for early referral. So we have to understand that they still have access issues and they still come from an underserved environment. So when we see these patients, this is the message we want to send after this study, and hopefully we'll continue to send the same message, is that when we see patients who are, Hispanic adolescents with severe obesity, it's going to be harder to get them to get the operation done. So that has to be a different mindset when we see them, a different mindset when we communicate with our colleagues and our referral system in the pediatrics world, that these patients are at a very high risk, and we need to keep a tight leash on them to bring them to specialized centers to undergo treatment. And I want to especially thank Talha Rafiki and Fareshte, who are our research fellows, did a lot of work collecting the data and analyzing it, as well as Ankasha Sabapati, my partner, Janie Pratt, who's been a great addition to our division and helped us grow our volume and develop our clinics in the outpatient world. And of course, the Department of Surgery and the JEDI Council for supporting us and helping us do the study this year. So thank you very much. I'm happy to answer any questions.